So hello friends, today we will be discussing the topic of anticholinergics, what we read yesterday. So we had some systems left. We discussed every system in pretty much big detail. Uh, Today I want to discuss. So today I want to discuss about the GIT. Okay, what is the effect of anticholinergics, the blockers on the GIT? Okay, what is the effect of anticholinergics on GIT? See, if I talk about the gastrointestinal system, normally you had a gastrointestinal tract which was working in a parasympathetic way and you were having a nice motility, a nice tone, a nice secretion, isn't it? You were having everything going in a perfect manner. But once you give a blocker, that means you will decrease the motility, that means you will decrease the tone, that means you will decrease the secretions, isn't it? So, what is the reason of it has been seen that uh, once we give anticholinergic, it will decrease the acid production. What is the reason? How is it happening? Any one of you comment on this? How is it happening that anticholinergics decrease the secretion? You are seeing parasympathetics are increasing the secretion. They are decreasing the secretion? The blockers. The reason is there. Which receptors they should be using? Which receptors they should be using, guys? That's where you get stuck. That is the thing. I told you glands, you have to remember a concept, isn't it? Yeah. So this is the concept M1. So that's where he will choke you in the exam. Okay. So let me make it like this. Let me make a diagram for you. How to tell you. Okay, let me draw it like this. This is a neuron. Okay. And this neuron is producing what? Acetylcholine. And this is a cell, that is parietal cell. Parietal cell secretes HCl. I hope you know this. Now this ACH will go to the receptors present on the parietal cell. Receptors on the parietal cell. Now this receptor, when it's activated, it will cause what? What receptor is there? Which receptor is here? This receptor is M3. This is where you get lagged. You don't understand, then you get confused. Oh, is it M1 here or M3? M1 is here. M1 is controlling the secretion. M1 is here. And M3 is here. Now what will listen to me and then you will ask me any question. Okay, just listen fully. Fully listen the topic and then don't in the middle speak something, because I will be answering your every question in the topic. Once you learn every topic, you don't have any question. Or maybe I'm teaching you something that it is answering your query. Okay. So listen fully and then you will not be having any question. I believe that. So now remember, parietal cell is not having M1 receptors. It is having M3 receptors, guys. It's having M3 receptors. But M1 is present on the neuron, the junction at which there is, that neuronal junction, NN junction. So what will happen? This M1 is secreting ACH, and ACH is going to the M3 receptors. M3 receptors are inside talking to what pump? Hydrogen potassium pump. This hydrogen potassium pump will secrete the acid. This will increase the acid. Now what I do? I put a blocker. Here. Block. I put a blocker. I gave an M1 blocker. What will happen? I will not be producing AC. I will not be stimulating the M3 on the parietal cell. I will not be stimulating the H positive potassium pump. I will not be increasing the acid but decreasing the acid. That is how M1 blockade is decreasing the acid. It is decreasing the acid. So can I say I can use these drugs as peptic ulcer disease? in the treatment of peptic ulcer disease, guys? Guys, can I say I am using these drugs as the peptic? Just answer my queries, my questions. Just can I say I will be giving this as a treatment for peptic ulcer disease? So which drugs I have? I have some selective ones. For example, I have pyrazine. So what are the M1 blockers we have? We have pyrazine, tilenzepine, tilenzepine. You all can use them for peptic ulcer disease, guys. You all can use them for peptic ulcer disease. Fine. So, is atropine an anticholinergic? Is atropine an anticholinergic? Is it a is it a blocker? Is it a blocker? Anticholinergic? Should answer fast. So, can I use that in peptic ulcer disease? Mm-hmm. The reason is not this. The reason is because they will have, if I give atropine will be having what? Muscarinic side effects also. Okay. But what is M3 doing? What is present on the smooth muscle? Yes, it blocks a muscarinic activity. So that means your answer is that means you are yourself giving opposite justification. Okay. So atropine is a muscarinic antagonist. Okay, it will be having muscarinic side. And also uh, the reason is that I can think, I don't know whether you are thinking, but in the brain I'm thinking I have M3 receptors on the smooth muscle cells. I have M3 receptors on the smooth muscle cells. So these receptors will get blocked. That means M3 was normally causing motility, but I will be decreasing the motility. That means whatever acid you have decreased, the food is already present there. You are exaggerating the situation. You are producing a, you are doing a, you are actually worsening the case. First, if you are having a nice acidity in the, that is also helping you in gastric emptying. I hope you know from your gastric physiology. When you are mixing the food very nicely with the acid, you are actually going to have an efficient gastric motility, isn't it? That is having an effect on the gastric motility. But once you are giving an M3 blocker will decrease the motility of the gut. And if it decreases the motility of the gut, it will be actually letting the food to remain stagnant at that place. That means the food with decreased acid processing is doing an additive effect there. It is doing an additive. It is actually worsening. It's making the situation worse. That's why we are not using atropine. That's a beautiful concept. And what will happen even if that person is having a peptic ulcer disease due to that stagnant food, whatever acid, that much acid is present there, that is also exaggerating the peptic ulcer disease. What a beautiful concept. Isn't it? It's a beautiful concept, very beautifully explained by my pharmacology and physiology. That if you have an M3 blocking activity that is present in the atropine, because a non-selective blocker, I am here using a selective blocker M1, that is pyrazine and tilenzepine, so that even if I am decreasing the acid, I am not doing anything with the smooth muscle cells. Is it fine? Is it clear? Do you have any doubt? So I have other drugs. So sir, there should be also some things when I have any sort of a spasm. When I have any sort of a spasm in the intestine, I have intestinal colic. Sometimes jerky that feels like something is taking your life. Right? That pain, the intestinal colic. So you should be using also some antispasmodics. So there should be some anticholinergics which are used for antispasmodics. So you have, for example, hyoscine. You have what else? Dicyclomine. You have oxyphenonium. These all can be used as antispasmodics. That's why you use it in the treatment of intestinal colic. Use it in the treatment of intestinal colic. Is it fine? Now I have a patient who is having an irritable bowel syndrome. In IBD, it can be a constipation or it can be diarrhea. So in the IBD, I have drugs such as I have darifenacin, I have solifenacin, solifenacin, or even because they are blocking what? They are blocking the M3. They are selective M3 blockers. So selective M3 blockers. Selective M3 blockers. Yes, this screen you want to see? Okay, you can. It's pyrenzipine, tilenzipine. Now, M3 you have to block. So darifenacin, solifenacin is used in the irritable bowel syndrome, and you can also use it in the bladder. Going to the bladder, I want to go to the bladder right now. Okay, I think GID. Bladder is a very nice. I want to teach you bladder. If you want, I can tell you all the drugs which I am using on the bladder. Okay. No relevant muscarinic drugs. Okay. Now, if you go into the structure of the bladder, this is forming a trigon. Okay. So you have, this is internal urethral sphincter. Let me make a clean drawing for you so that you can remember it for whole life. And this is your external urethral sphincter, guys. External urethral sphincter. External urethral sphincter. Okay, this is external urethral sphincter. This is internal urethral sphincter. Fine. Okay. Now you have muscles also around this. You have muscles around this. Let me take the muscle part. You have muscles around this. You have muscular layer that is called the detrusor muscle. I will relate everything, whatever you need in the pharmacology. Okay, it will help you. Definitely, it will help you. Fine. Now, what receptors are mostly present on this muscle? You have M3 receptors, muscarinic. If I talk, it is muscarinic. It's muscarinic, isn't it? It's muscarinic. And if I talk about, if I talk about, I don't want to go in the, we haven't read this, adrenergic system, isn't it? So I would not like to go there, but I would say M3. Okay, M3 from this point of view. Now listen. Now, the nerves which we are getting here, we have which nerves? So the nerves which I am getting here is, one nerve I am getting is the parasympathetic nerve. So the parasympathetic nerve by pelvic nerve. Pelvic nerve is giving me the supply here. Okay. And I also have hypogastric nerve supply. Hypogastric nerve supply. And what nerves are supplying? Hypogastric nerve. But hypogastric nerve I won't be using here because I have to talk about muscarinic. I won't be using that right now. Otherwise it will confuse you. Okay. And I also have this pudendal nerve. Pudendal nerve is supplying to this part. Okay. Pudendal nerve. So I want to please make me remember that I have made this diagram so that once I come in the sympathetic nervous system, I will take this diagram again. Okay. So see, what I want to do is, see, in the bladder, normally in the parasympathetic activity, you are using the bladder, you are urinating. That is, you are activating the M3 receptors. You are activating them. But once you want to block it, you want to do a urinary retention, what you will do, you will you will actually be accommodating the more of amount of the urine. You'll be accommodated more amount of the urine here. So you will accommodate. Once you give a blocker, what will happen? You won't contract the muscles. That means you will make the bladder to retain the urine. Make the bladder to retain the urine. So once you retain the urine, that means you are doing a urinary retention. That means you are not relaxing the bladder. That means you are not relaxing the bladder. So you are relaxing the bladder actually. Okay, you are relaxing the bladder, and you are not doing any M3 activity. You gave an M3 blocker. Given M3 blocker. Fine. Now tell me one thing. The patient comes to me with, so prostate is also present here, isn't it? Prostate is also here. I have prostate around this. Now tell me one thing. A patient is having a condition that is called BPH. BPH is benign prostate hyperplasia. Benign prostate hyperplasia. In benign prostate hyperplasia, I am having an enlargement in the prostate. I am having an enlargement in the prostate. See, prostate is getting enlarged. Will it block the canal? Will it block the urethra? Will it block the prostatic urethra? Will it block the prostatic urethra? Friends, my dears, will it block the prostatic urethra? Yes, it will block the prostatic urethra. Do you want the urine to retain in BPH or pass in BPH? Do you want the urinary to retain in BPH or pass in UC? Just tell me this thing, that pass or you want to retain. You want to pass because you are already having a enlargement of this, so you will get retention already. So do you want to give M3 blocker in a BPH patient? Will you give M3 blocker in a BPH patient? Never. Never. That will be a blunder. That's why we say it is contraindicated in BPH. M3 blockers are contraindicated in benign prostate hyperplasia. Is it clear? Everything is with a concept. It's not anything of mugging up. Pharmacology is tasty. I'm telling you, fall in love with pharmacology. If you are fearing microbiologists, come to me. I will remove all your fears. There is no fear. It's all conceptual. Nothing is being taught something which is out of this world. M3 blocker contraindicated in benign prostate hyperplasia because it will again cause that urinary. So we have district forest officers, isn't it? Do you know district forest officer? Do we know district forest officer? Yeah. Do we know district forest officer? What? District forest. District forest, you have seen that whenever you went to a picnic, someday, with your memories, with your loved ones also sometimes. So you used to go with picnic. You used to go to picnic with your classmates, isn't it? There you used to enjoy, isn't it? So what happened? You know that some boys, they went to find a place in the forest so that they can do that. Okay, this pee. Okay, so that they could pee. So what they do? They search a place. That's how I remember this DFO. Okay, district forest officer. Okay, so if someone is, now I want to tell you what DFO we are using. Before seeing this DFO story, I want to tell you, when you are giving a parasympathetic supply, once you are stimulating parasympathetic, parasympathomimetic you are giving on the bladder, what will happen? You will have a voiding of the urine. You will void the urine. If you stimulate M3, you are voiding the urine, isn't it? But if I have already a patient who is having a urinary incontinence or detrusor instability, that's a beautiful concept. If I have already a patient who is having detrusor instability, or the patient is having renal colic, or the patient is having what? Urinary incontinence. Is not able. I have taught you, you should refer to which video. I have taught you everything. The terminologies of urinary frequency, urgency, intermittency, dribbling, post-micturial dribble, bladder outlet, obstruction. Which video did I taught it? I want to refer here for my viewers. Yeah, microbiology, which bacteria? E. coli. So everyone should check, the viewers who are watching the video, please go to E. coli. I have taught there everything about urinary tract infections. I have gone into more detail. Okay, so please refer to that E. coli. Okay, so see, renal colic. Renal colic, we are giving this. So I have taught you what is renal colic, what is urinary incontinence. So I don't need to explain it here because I have taught in that video. So see, detrusor instability. Detrusor instability means he's having overactive bladder. Overactive bladder. He's peeing all the time. He's wetting the bed. No, again and again. So you will be giving some blockers, M3 blockers to prevent this urinary incontinence. So we have DFO drugs. So what is DFO drug? It's non-mnemonic, by the way. Every mnemonic what I taught is pretty much 90% from my brain. DFO, district forest officer, it is dicyclomine. Dicyclomine. Okay. Flavoxate. Flavoxate. Oxybutynin. Oxybutynin, guys. You use it for urinary incontinence. Now, if you want a selective action, there are also drugs. If you want a selective action, because we have also, what to say, we have solifenacin, darifenacin, tolterodine, isn't it? Trospium. So you should know them, which are selective, which are not selective. So which of them are selective? So there was also a mnemonic. Soft was also there, a mnemonic. Okay, some people remember by soft also. So DFO I remember first for the urinary incontinence. But if I have to remember selective M3, selective M3 will be which will be selective M3, guys? Tolterodine. Let me write the mnemonic for you. Okay, if you want to. Soft. Famous mnemonic. Everyone remembers like this. So solifenacin, oxybutynin, flavoxate, or you can also remember physoterodine. Physoterodine, and T is for tolterodine. Or I told you in the about trospium. Trospium, guys. Is it clear? Trospium. So solifenacin, oxybutynin or darifenacin, flavoxate, osterodine, tolterodine, trospium. Trospium, what? Trospium. Solifenacin, darifenacin, and oxybutynin. What to say? Oxybutynin. Oxy. You don't speak with me because that's how you forget the drugs. It needs hell lot of revisions to learn. Then only you can prescribe this drug. Otherwise, it's something which is not possible to learn. Oxybutynin. What? Oxybutynin. Flavoxate. Tolterodine. Trospium. What? Trospium. Physoterodine. What? Physoterodine. Salt. What is salt? Salt means bladder is relaxed. That means I should give what? I use these drugs to make it not soft, because soft bladder is contracting. Sorry, soft bladder is relaxed. Okay, I want to make it relax. I'm saying opposite. Okay, don't make the mnemonic wrong. I mean, I have to give blocker so that I can contain the urine. I'm having urinary incontinence. But who is selective M3? Selective M3 of them is soft. Selective M3. Who? What about flavoxate, oxybutynin? They are just, we are not talking about the selectivity. In this case, we're talking about selectivity. So which of the following is best for which is basically, we call it vesicoselective. Who is vesicoselective? It is solifenacin. Solifenacin is vesicoselective. Selectively works on the bladder. Vesicoselective. Fine. Okay. Uh, I was about to speak something. Some thought came in my brain. What I had to say? Yeah. So solifenacin, or even you can say darifenacin. Okay. They are vesicoselective. Okay. They are vesicoselective. Now the beauty of all are having an adverse effect of what? They will cause dry mouth. They will cause dry mouth. But trospium has a special feature. It does not cause the CNS. It does not cause the BBB. Okay, it does not cross the BBB. So you won't be having any CNS blocking effects. You won't be having any CNS blocking effects. CNS blocking effects, guys. Is it clear? Okay. So which of the following is the shortest acting? Oxybutynine or solifenacin? Oxybutynine, oxy is short. Solifenacin is longest. But soli long. Solifenacin. Solifenacin long acting. Okay. Now I want to tell you a new drug that is mirabegron, but that is used for what? That is basically that works by B3 receptor. So I don't want to tell you that. Okay. I will tell you that in the adrenergics. Okay. Fine. Now, how will you treat? I have a question for you. How to treat overactive bladder? How to treat overactive bladder? Answer. We have first line management. First line management is what? No drug. No drug. We give behavioral therapy. We give behavioral therapy. That is, you will train the person. That we call the bladder training. Will give the bladder training. You will tell him to do pelvic floor exercises. Pelvic floor exercise. I hope you remember pelvic floor. It's not that he has to do exercise on the floor. It's pelvic floor. Okay. The floor of the pelvis, anatomical floor. The pelvic floor exercises. These all you can tell them. That is the first line management. The second line management will be drugs now. That you can use, okay, for overactive bladder. Is it clear? So can you tell me one thing, why trospium is not able to cross the CNS? Because it is a dash. It's a quaternary amine. It's a quaternary amine, isn't it? It's a quaternary amine. This is all a concept which you should know. Is it fine? Is it clear? Now we have, okay. I want to teach you another topic, that is the, in this, I want to tell you we have onna botulinum toxin. Do we remember the botulinum toxin? Onna botulinum toxin A. Okay, onna botulinum toxin A. Next toxin, pra botulinum. Pra means dad. In some language, pra means dad, isn't it? Or brother. It means brother, I think, in some language, isn't it? Pra means brother, isn't it? So onna botulinum A, pra botulinum toxin A. Then another botulinum toxin A. Botulinum toxin B. Okay. So what is botulinum toxin A? This is actually a newer, we are using this drug now in people who, an adult comes to you, an adult patient comes to you with headache, with migraine. Actually, you have diagnosed that person with migraine. So in migraine, they will have headaches, isn't it? They will have headaches. So to prevent that headache, you can give what? Botulinum toxin A. This is a latest, recently I think I read it somewhere. Recently means 1 year ago. Okay. So adult migraine patient, if he is having headache, to prevent that, you can give botulinum. Botulinum toxin is, let us talk about some beautiful girls, okay? Let us talk about some beautiful girls. Beautiful, beautiful girls, okay? Let us make their beautiful eyes. I am thankful to my drawing teacher that she at least taught me how to make this. Otherwise, I can start making frog, isn't it? I don't know how to make diagrams. So let us make her. Wow. Oh, big lips, okay? Okay? Very big lips. Beautiful. Okay. Okay. Now she's more beautiful. I like her. Okay. Now see, you have seen, have you seen the lines on the forehead with aging? Now she's getting aging. She's going into aging. Okay. So she has globular lines. She has globular lines, for example. If she has globular lines. So for this globular line, you are giving what? You are injecting it. You are giving her, you tell her to raise the shirt, and you want to give her what? In the IM. You want to give her in the IM. What? What you will give her? Botulinum you will give IM. Okay, so that her lines can improve. So that her lines can improve. What about botulinum toxin A? Botulinum toxin A also used in this case. But what are the other uses of botulinum toxin A? Botulinum toxin A, we are using it. There is a condition in ophthalmology that is called blepharospasm. We have lid spasm, blepharospasm. So in blepharospasm, we want to relieve that spasm. We are giving this botulinum toxin type A. Also, we are using this in strabismus. We have oscillatory movement, to and fro movement, strabismus. Okay. No, not for strabismus. Strabismus, we are using this. Okay. Strabismus, yeah. We are using this for strabismus. So we are using this botulinum toxin A for blepharospasm, or even in cases of cervical dystonia. Okay, remember that. Cervical dystonia. Dystonia. Okay. Now what about this botulinum toxin B? Botulinum toxin B. Sorry, botulinum toxin B is used for cervical dystonia. Okay, see, it confuses me also. So botulinum toxin A is used for what? Blepharospasm, strabismus, globular lines. But B, cervical dystonia. I remember that. So I think botulinum toxin A is also used in cervical dystonia. I had read somewhere, but to be more specific about B, I will say cervical dystonia. Okay. So botulinum A can also be used, I think. Okay, it can also be used. You can check the books also, but B is specific. B is specific for cervical dystonia. Is it there? Okay. So this botulinum toxin is for headache. And how much will you be giving? You will be giving every 12 weeks. Every 12 weeks, you will be giving this injection according to the intensity, whatever. Okay. Now I want to end this parasympathetic, okay, anticholinergics with mushroom poisoning. Pink color for girls, isn't it? Mostly girls in our class. So, mushroom poisoning. Mushroom poisoning, there are species of mushroom. Yes, yes, yes. Yes, yes, cosmetic purposes. You are very right. We are using this for cosmetic purposes, okay? Yes, these are all cosmetic values, but yeah, strabismus and blepharospasm is an ophthalmic indication. Okay, ophthalmological indication. Strabismus and this. Yeah, strabismus can also be told it is a uh, cosmetic value. Okay, okay, fine. So mushroom poisoning. Mushroom poisoning. What to say about mushroom poisoning? There are two species of mushroom. I hope I remember. We had basically we divided mushroom poisoning into two. We used to say one is an early mushroom poisoning, another is a late mushroom poisoning. One is an early mushroom poisoning, another is late mushroom poisoning. So early mushroom poisoning is caused by inocybe clitocybe. Inocybe clitocybe. Inocybe, let me write inocybe. Clitocybe. Okay. All these species, inocybe clitocybe species, think how I remember them, their symptoms is they behave as if you had an organophosphate poisoning. This is how I learn it. Whenever I have an early poisoning, it is mostly by which species? Inocybe, clitocybe. So the symptoms of the patient will be same like of organophosphate poisoning. Organophosphate. Are we understanding? So think whenever he tells you patient is coming with early poisoning with inocybe species, the food was found to be inocybe variety, you have to think, yeah, see, he will say which of the following cannot be the symptoms or which of the following symptoms best describe this poisoning. You have to remember as if you are seeing a patient of OP poisoning. Are we able to understand, guys? This is the how we can make life easy. As if you are seeing a patient of OP poisoning. So you have to remember that. So this inocybe clitocybe is as if you are seeing an OP poisoning patient. So I remember. As if you are seeing an OP poisoning patient. So what will be the drug of choice here? Atropine. Atropine, because of atropine. The drug of choice will be atropine, guys. Drug of choice will be atropine. I go to the late poisoning. Late poisoning is mostly done by my girlfriend Amanita. I'm kidding. My girlfriend Amanita muscaria. Amanita muscaria. What else? Amanita muscaria. Remember one only. Amanita muscaria. Okay. It is think think as if it is opposite now. This is how I remember. This is tricky. Think as if you have atropine poisoning. Whenever you have a patient with Amanita muscaria, okay, Amanita muscaria poisoning, what you will see? You will think as if he had atropine poisoning. Atropine poisoning. What are the signs of atropine poisoning? What are the signs of atropine poisoning? Who can tell me? What are the signs of atropine poisoning? Mm-hmm. You should start writing, not looking at me, guys. What are the signs of atropine poisoning? Okay, we are talking about muscarinic effects. Okay, muscarinic blocking effects. Okay, fine. What else? Let us give you time, one minute to think, so that we end this discussion. Yeah, you should all use your all knowledge. Okay, talented pupils, very nice. Block muscarinic secretion, less secretion. Okay, some people are adding something, very nicely. What else? So I had taught you last time, red as a beet, hot as a hair, fast as a fiddle, dry as a bone, full as a flask. isn't it? Do you remember that? Do you remember that story when we had played the song? Which song? Which song? Which song? The song is My Heart Will Go On, isn't it? Titanic. My Heart Will Go On, isn't it? Do you know that song? I don't know whether you know that song or not. Do you know that song or not? My heart will go on and on and on. Isn't it? Sing this song to a loud one, isn't it? So let me say that song here also. So the temperature of the body will increase. That's why you say hot as a hair. Yes. Then heart rate will increase. Heart rate will increase. Okay. Then dry mouth. Then flushed skin. Flushed skin. Isn't it? Then red as a bead, isn't it? So then what I remember? Cycloplegia. Cycloplegia and disorientation. Disorientation. Then urinary retention. Okay. Now what happens in some exams? What the trend is that they put it as they will say a person was you know you know he had a weed datura that is called Jimson's weed. Jimson's weed. So this Jimson's weed is causing a condition that is called Gardner's pupil. Gardner's pupil. This Gardner's pupil means he has taken some alkaloid. This is an alkaloid, and this causes mydriasis. Remember this. They may ask this question, okay, so that you can click it in the brain that it is talking about the adverse effect of all these. Okay, is it clear? So where are the anticholinergics contraindicated? I taught you two contraindications: angle closure glaucoma and BPH. Angle closure glaucoma and BPH anticholinergics. I hope you have enjoyed this topic. We have today in this video finished the parasympathetic, lytics, lytics, anything ticks, whatever ticks there is, sympathetics off only, parasympathetics. Next video we will be tomorrow talking about the sympathetics. Okay, and we are moving towards the last 50% of the autonomic nervous system drugs. Okay, and we will be continuing the pathology next time. Okay, so thank you very much. Enjoy MBBS. Take care. Stay safe. Bye bye.